Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 450 of our pharmacotherapy series, which majors in lung cancer. The first case reads, a 69-year-old male patient, JOW, was found to have a 3 cm nodule on a chest X-ray done prior to an elective cataract surgery. The patient was a lifelong cigarette smoker, having started smoking in his early 20s, approximately 1 pack of cigarettes per day. He quit smoking 9 years ago. So my questions to you read: what screening methods might be available to detect the disease in asymptomatic patients? What risk factors does JOW have for lung cancer? The National Lung Screening Trial, abbreviated as NLST, was a randomized study comparing low-dose CT scans with chest radiography in over 50,000 patients with a heavy smoking history, examining lung cancer mortality. The National Lung Screening Trial did result in a higher incidence of confirmed diagnoses of lung cancer with low-dose CT, resulting in a 20% relative reduction in the rate of death from lung cancer. However, low-dose CT scans did result in a higher rate of false positives than chest radiography. The National Lung Screening Trial did result in the U.S. Preventive Service Task Force making a recommendation of annual screening for lung cancer with low-dose CT scans in adults 55 to 80 years old with a 30-pack-year smoking history and currently smoke or have quit within the last 15 years. The probability for developing the disease increases with age, and JOW's age is close to the median age of peak incidence. Men also have a slightly higher risk than women, as discussed previously. Smoking is the largest risk factor for lung cancer development. However, what if a person stops smoking? Does the risk decrease with time? These questions are important for healthcare providers to address whether they are encouraging smoking cessation for their patients. In JOW's case, he stopped 9 years ago. So what impact would this smoking history have on development of the disease? In general, people who stop smoking, even well into middle age, avoid almost 90% of the risk attributable to tobacco. JOW stopped when he was approximately 60 years old. Therefore, the cumulative risk would approach 10% if he were 75 years old. Because he is 69 years old, his risk would be decreased, but not to the extent that it would if a longer period of time had elapsed. If he was still smoking, the risk would be expected to be closer to 16%. Hence, smoking cessation is an effective means for lowering the risk over time. He smoked for approximately 35 to 40 pack years, so the total number of cigarettes would also increase his risk. According to data from the same studies, Risk of disease for a 1-pack per day smoker would be approximately twice that of someone who smoked less than a half-pack per day. Survival from the disease is also better for non-smokers than for smokers. Frequently, patients will experience remorsefulness for having smoked, but it is never possible to attribute one's disease to a single factor such as smoking. In fact, 90% of smokers never exhibit the disease. Furthermore, 15% of men and 53% of all women with lung cancer worldwide are never smokers. This suggests that other factors such as genetics are associated with the development of the disease. Research has been directed at identifying genomic-associated factors that have the potential to lead to the development of lung cancer in both smokers and non-smokers. It has been shown that there can be some genetic associations, but the true impact of these genetic polymorphisms has not been fully elucidated. A more thorough history from JOW would be helpful, but recall for exposure to pollution, chemicals, and second-hand smoke exposure is difficult to quantify. Hence, the view held by much of society that lung cancer is a self-inflicted disease is not entirely true. In summary, there is limited history on JOW's exposure to environmental hazards such as radon and second-hand smoke. His age is close to that of peak incidence. Although he stopped smoking almost a decade ago, there is still some residual risk associated with past smoking history, and this would be expected to be higher for those with many pack years history. Due to his heavy smoking history, JOW may have benefited from low-dose CT scan screening to potentially provide earlier detection of lung cancer. A CT scan was ordered for further evaluation and it showed an isolated spiculated nodule in the right upper lobe with no mediastinal or hilar adenopathy. The nodule showed no calcification. A CT-guided needle biopsy was performed which showed a well-differentiated adenocarcinoma consistent with a primary non-small cell lung cancer abbreviated as NSCLC. Further staging was carried out with PET scanning that demonstrated no additional areas of disease except for the nodule. My next questions to you read: what would be the best treatment plan for JOW, given the current information? Would surgery or neoadjuvant therapy be indicated? The goals of therapy for this patient are to achieve a cure, especially since the disease appears to be in the early stage. Surgery is the best treatment modality for patients with stages 1 and 2 disease, because these tumors are limited to one hemithorax and can be readily removed by excision. In most instances, lobectomy with node dissection is sufficient for local control. During surgery, the nodes would be sampled for presence of the disease and to confirm staging. JOW appears to have limited disease, and so lobectomy would be recommended for him. For patients whose primary tumor or lymph node involvement extends to the proximal bronchus or proximal pulmonary artery, or crosses the major fissure, then a more extensive pneumonectomy is performed. Therefore, surgery is the treatment of choice, and final staging during surgery will guide further adjunct treatments. The tumors can often spread to mediastinal lymph nodes, and for those patients, stage 3A, then neoadjuvant chemotherapy can be recommended to reduce the tumor burden prior to surgery. If neoadjuvant therapy is chosen, the regimen is usually similar to those used in the adjuvant setting. Therefore, surgery is the primary treatment modality for patients with stages 1, 2, and early stage 3 disease. JOW's disease appears to be localized. Therefore, surgical removal of the tumor would be indicated, and neoadjuvant chemotherapy would not be indicated because there does not appear to be disease in the mediastinum. JOW was referred to a thoracic surgeon for resection. A right upper lobe lobectomy was performed with lymph node dissection. The pathology report revealed a 3.2 by 4 cm adenocarcinoma with 3 associated peribronchial lymph nodes containing cancer cells. Lymph nodes sampled from the mediastinum demonstrated no cancer. The patient's tumor was staged as AT2N1M0, stage 1-2A, non-small cell lung cancer. Now that the tumor is removed and staging of the disease is finalized, what additional therapy, if any, is recommended? Although non-small cell lung cancer tumors are minimally responsive to chemotherapy, evidence from several studies demonstrates that adjuvant treatment enhances patient survival, and therefore should be considered as part of the treatment plan for the patient. Though adjuvant treatment is often recommended, results from 2 other studies indicate that adjuvant treatment is not always effective. This suggests that there is a need to identify subsets of patients who would likely benefit from treatment, and one group that does not seem to gain benefit are those with stage 1 disease. In the CALGB 9633 study, patients were randomly assigned to receive carboplatin and paclitaxel or placebo, and a survival benefit was observed for those receiving chemotherapy. However, this survival was not uniform across the entire cohort. Subgroup analysis showed that adjuvant chemotherapy should not be considered standard of care for patients with stage 1B disease unless the tumor size is greater than 4 cm. Collectively, these studies show that patients with stages 2 and 3A disease gain the most benefit from adjuvant chemotherapy. This chemotherapy usually includes cisplatin or, if the patient is unable to tolerate it, then carboplatin. A second agent is added as doublet therapy, and the goal is for patients to receive 4 cycles. Toxicity often becomes worse beyond 4 cycles and benefits are diminished thereafter. Therefore, cytotoxic chemotherapy is beneficial but has its limitations. Radiation therapy is frequently used in the treatment of malignancies, including later stages of non-small cell lung cancer. However, it has no proven benefit for the treatment of early-stage disease. The PORT group conducted a meta-analysis from 9 randomized trials to evaluate the possible role of postoperative radiotherapy in patients with completely resected non-small cell lung cancer. There were 707 deaths among 1,056 patients assigned postoperative radiotherapy and 661 among 1,072 assigned surgery alone. Hazard ratio 1.21, with a 95% confidence interval of 1.08 to 1.34. This 21% relative increase in the risk of death with radiotherapy is equivalent to a reduction in overall survival from 55% to 48%. Subgroup analysis showed that the increased risk of death was greatest for patients with stage 1 or 2, N0 or N1, but no clear evidence for those with stage 3, N2 disease. Separately, another postoperative radiotherapy study was conducted, using data from 7,465 patients in the surveillance, epidemiology, and end results, abbreviated as SEER, database. The investigators for this study also found no benefit for radiotherapy, especially for patients with N1 and N0 nodal disease. However, an increase in survival was associated with radiotherapy for patients who had N2 nodal disease. Consequently, radiation therapy is reserved for patients with more advanced non-small cell lung cancer. In summary, adjuvant cytotoxic chemotherapy is recommended for all patients found to have stage 2 or 3 non-small cell lung cancer at surgery, as well as for larger, that is larger than 4 centimeters, tumors. Multiple prospective Phase 3 studies have shown that platinum-based chemotherapy after surgery will increase the survival rate of patients after surgery by about 10%. Because JOW has stage 2A disease, 4 cycles of a platinum-based doublet regimen would be indicated after surgery. However, he should not receive radiotherapy at this time. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 451.